Oh, the camera's here. You want me standing here? Good afternoon, everybody, and welcome to our next Dean's Leadership Lecture in the series that occurs throughout the academic year. For those of you who are not normally in this building, welcome to New York Medical College and to the School of Health Sciences and Practice. I'm Rob Ambler, I'm the Dean, and it's my pleasure to introduce our speaker who has come all the way from that great city in the north known as Boston, Massachusetts. Dr. Tom Feeley is a senior fellow at the Harvard Business School. He is, I did say business school. He is also Professor Emeritus at the University of Texas MD Anderson Cancer Center in Houston, Texas. For 20 years, he was the Helen Schaefer Fly Distinguished Professor of Anesthesiology at the University of Texas MD Anderson Cancer Center. He headed the Institute for Cancer Care Innovation until 2017, when he joined Harvard Business School full-time. He received both undergraduate and MD degrees from Boston University. He received his graduate medical training in anesthesiology and critical care medicine at Beth Israel Deaconess Medical Center, which is, of course, one of the major teaching hospitals of Harvard Medical School. He also was a faculty member at Stanford University for nearly 20 years, practicing cardiovascular anesthesia and critical care medicine. In 1997, he came to the University of Texas MD Anderson Cancer Center to create and lead the Division of Anesthesiology and Critical Care. He was there again for nearly 20 years, and he was the head of that organization, which grew to be the largest program of its kind devoted to cancer anesthesiology and critical care medicine. He also served for 7 years there as the vice president of medical operations. His work leading the Institute for Cancer Care Innovation focused on research to demonstrate and improve the value of cancer care delivery based on the work of Harvard Business School professor Michael Porter. So Dr. Feeley is truly an interdisciplinarian, not just a multidisciplinarian. He joined the Harvard Business School faculty when he came there initially in 2014, working in the Institute for Strategy and Competitiveness with Professor Michael Porter and also Professor Robert Kaplan. These are names everyone in the business world immediately recognizes. He worked on research and education in the value-based healthcare agenda with an emphasis on the role of information technology in healthcare. His interests now also include the implementation of value-based healthcare through outcome measurement, cost measurement, and alternative reimbursement strategies in delivery systems worldwide. He is truly a Renaissance man in our joint fields of public health, medicine, critical care, and value-based healthcare delivery. Please give a warm New York Medical College welcome to Professor and Dr. Thomas Feeley.
Thanks, Rob. You emphasized the business school part, but I still have a little trouble walking on the campus of Harvard Business School saying, now, what am I doing here? But it's really a delight to be here. Rob took one of the courses, and we've gotten to know him and know some of the faculty. And so I'm looking forward to telling you what we've been doing. So thank you.
Great. And I've been asked to make sure that you're in full view of the camera.
Okay.
To say there's actually quite a group that are, and just.
Okay, well, I may move around, and my apologies who are trying to look at me. That always makes me really uncomfortable. So this reminds me of sort of a YouTube thing, and I'm not sure I want to be a YouTube personality. So what I want to talk to you about is the work that we've been doing really over the last 10 or 11 years with Michael Porter at Harvard Business School to try to look at what we can do better in healthcare. So I practiced medicine for over 40 years and took care of patients in the system that really hadn't changed. And if I look back at my residency and then look at what I did at Stanford and what we did at the University of Texas, it was all in the same system. Yet the system is broken. And I think most people would acknowledge that the system is broken. And it costs too much. This is not a uniquely American problem. This is a problem that faces healthcare delivery systems in the world. Our costs are going up to our gross domestic product. And that problem, while it sort of fluctuates from time to time, it's not getting any better. And so we've looked to systems that try to change this, but our costs are high. And if the United States were honest about it, while we say we have a great healthcare delivery system, when we look at some of our outcomes like life expectancy and maternal mortality, we do worse than many countries who spend half of what we do. And so this is a real problem. And we can pat ourselves on the back of a lot of multiple technologies, but we have so many stakeholders, and everybody has a piece of cost overrun, if you will. We also have a problem with what to measure. And we measure now almost everything, but nothing is necessarily as meaningful as we would like it to be. We do a lot of process measurement, but we don't really focus on things that matter to patients. However, there is an entire tendency for people to really change our reimbursement system so that we're reimbursing for value. And I'll talk a little bit about what we mean by value, and rationalize how we deliver care. Because I think anyone, if you think back of anecdotes of your experience with the healthcare delivery system, you can think of one doctors also come across examples where every one of you tell me stories of you can't believe in the healthcare delivery system. And most other industries don't have that persistent problems. All right. How can you tell, by the way? Oh. Let's try that. All right. Is this better? So far, 3 words. Look, I've experienced all of these different. How are we doing? All right, that's 10 words. So I've been through all of these things where we've tried to come up with solutions. We've looked at evidence-based medicine. Let's use the right evidence. We've had incredible programs to try to improve safety. We've had doctor authorizations and check with their insurance company if they for it. We've engaged patients as have more stake in the game. We thought electronic medical records would help. And if you ask any doctor about what they think about electronic medical records, they're not going to be terribly complimentary. We've done Lean and Six Sigma, and we've gone out there with all of these Toyota things, but doctors really don't like to be thought of as manufacturers. We've thrown in care coordinators, and who were we talking with? We were talking about care coordination. That's a Band-Aid. No offense, but it's a Band-Aid. We try to bring people in to coordinate a broken system. Mergers, consolidations. None of these have made the system any better. They've cost more. IBM Watson, thank God I walked away from IBM Watson. They approached us at MD Anderson a number of years, but a lot of friends didn't. And it's a total sham. It does not work. It does not make healthcare any better. Personalized medicine. Lived in the cancer world, and everybody thought, oh, personalized medicine, we're going to figure out and we're going to direct therapy. These work. What really needs to happen is that there needs to be a fundamental restructuring of how we deliver care, how we think care should be delivered, and this is not easy work, but if you bear with me, I'm going to try to go through what we think is a rational transition from current healthcare system to a healthcare delivery system that makes sense. How are we doing? You know, well, I guess you're recording it. I can speak loudly. I'm got it. Okay, all right. So what's wrong? Our legacy system is really, as I mentioned, it's the same system that we had when I trained. I was trained as a anesthesiologist. We had our territory. Our territory was territory. Surgeons, their territory. Interns, their territory. Go to the specialties, pediatricians. They all have their territories, but we all work in teams. And some of this legacy structure of specialty-based medicine really caused the system to be incredibly fragmented. Tremendous advances in medical science have been really remarkable. There isn't a drug, except for oxygen, that I used in my residency that I would use now in clinical anesthesia. Thank God we still use oxygen, it's helpful. But that's it. Everything else has changed. But our delivery system hasn't changed. We do it exactly the same way as we always did, but we've got more specialties, more specialists. So what's wrong with it? We had a different focus, and towards the end, I want to talk about how we train leaders and leadership, but we've done the same thing, same way in what we call modern medicine, and the system hasn't changed. What's needed is we need to have a change in the delivery system, and we need a unifying goal. Goal that we're going to talk about is to consider that the goal and purpose of healthcare should be to deliver value for patients. And we were talking earlier about what are the real constraints in using value as a term, that everybody thinks of value in some different way. Lots of people value as less troubled.
Hold this.
I will hold that.
I'm sorry.
That's okay. No.
Check 1, 2. Hopefully.
Okay. Thanks. I'm glad you stayed here.
Yeah.
This working? Yeah. Oh, okay. All right. I feel like I should be doing something with my other hand here, but I don't have one. Okay. So if the
Check it.
Yeah. Are we all right? All right. So if value is the fundamental goal, we need to be sure we're speaking the same language. So value in healthcare should be the outcomes of care that matter to patients, balanced by the cost to achieve those outcomes. And I want you to keep that in mind as the fundamental goal, and that the definition of success is achieving high value. If you talk to a lot of people about, does that make sense? It's a unifying goal. The nurses would agree with us. The physicians agree with us. The health commissioners in the state of New York would agree with us. The politicians agree with us, and patients agree with us. So there's no disagreement, but getting to improving that value is a real challenge. But so the question is, how do you design a delivery system that achieves high value? It can't be the way we measure things now. Right now, we measure things at the level of the hospital or of a given practice. But you can't assess the value of a hospital because a hospital has patients with all sorts of problems admitted to it. They've got obstetrical patients, they've got cancer patients, they have pneumonia patients, they have patients at end of life, and they have children. That you can't assess how a hospital is functioning in a value-based system by any metric. And so what do we default to? We default to things like, what's your infection rate? Well, you know, should I pick a hospital I'm going to based on their infection rate? If that's the only thing they publish, well, I guess that's okay. But maybe I'm not really worried about an infection. So we've got to stop thinking about these old units of measurement and start thinking about how do we create value based on what patients have. And so the first principle of all of this is we need to start thinking about organizing care and delivering care based on the condition or the conditions that patients have. And again, there's a set of outcomes for those conditions, and there are a set of costs associated with them. And we'll talk a little bit about that. In primary and preventative care, in primary care, we have a real problem because primary care sees a little bit of everything. But if you think about primary care, there are healthy adults, there are patients with multiple comorbid conditions, there are women's health, and we can segment primary care into condition-like segments. But value creation and value measurement needs to be focused on medical conditions, and that's the basis of the work that we've been doing. Now, Professor Porter wrote his textbook about this back in, I'm not quite sure I'm doing this right, but back around in 2006. The number of peer-reviewed publications in value-based healthcare has really been increasing exponentially, and every year we're seeing more of it. And it's now an academic discipline that people are getting their PhDs in value-based healthcare. We're consulting with a program in Europe that's developing a master's in value-based healthcare. It is gaining increased interest. So what are the basic principles? There are 6 principles, and I'll go through some of the examples of the research that we did at MD Anderson with respect to each of these. But the first is that care needs to be reorganized around the conditions that patients have. And Professor Porter likes to call these integrated practice units. Nobody else does. I just, as a, sort of, he's not here, so I can say that. But we called them multidisciplinary care units. But at MD Anderson, we organized our care around the conditions that patients had. We didn't have a surgery clinic and a medicine clinic. We had a breast center for patients with breast cancer. We had a thoracic center for patients with lung cancer and esophageal cancer. We had a brain and spine center. So we organized around the conditions that patients have. And for primary and preventative care, there are segments of the population, and we are starting to get examples of primary care practices that are focusing on segments in primary care. The second basic principle is measurement, and we have to be measuring the right things. Right now we measure tons of stuff, but they haven't really improved healthcare. They've made us comfortable because our accrediting bodies want to see us measure those things, but we haven't made things any better. What do we want to measure? Well, the value is outcomes and cost. We should be measuring our outcomes and the cost to achieve those outcomes. Much easier said than done, mind you, but these are really basic, straightforward principles. The third thing is that we need to reimburse people based on achieving good outcomes. There's no industry in the world that pays you for a bad outcome, except for healthcare. If you have a complication, guess what? Your doctor gets paid more because he has to do something else. You couldn't have your car repaired and have a lousy job done and then go back and have on a, it's like, well, I work fee for service. It's like, yeah, I didn't do a very good job repairing your car. Your radiator's still leaking. I didn't, but I'm going to charge you more for doing that. But we do that in healthcare. How crazy is that? How ridiculous is our reimbursement system? We pay for procedures and volume, and we have to move away from that and pay for the outcomes that we achieve. We'll talk a little bit about some of these value-based reimbursement systems that are starting to appear. They're not taking over the world, but they're there, and they're becoming prominent. We need to have care delivery systems that are rational. We can't keep having and I don't know the New York metropolitan area, but you probably don't need a full service hospital that does everything for everyone every 5 miles. And I know that's the way it is in Boston. We have a group called Partners. They're responsible for the Brigham and for Mass General. They're about 4 miles apart from each other. They each have a kidney transplant program. They each have a cancer center. And that is totally irrational and not necessary. And it actually decreases value in a way that I'll talk about a little bit. So we have to have rational ways of providing the right care in the right location. And we need to reward centers of excellence. There are centers of excellence for certain specialty conditions, but we don't need every healthcare organization to be a center of excellence for everything. It just doesn't make any sense and is unlikely to occur. And finally, the sixth principle is there needs to be an enabling information technology system that allows us to collect those outcomes in a seamless way, not ask doctors to record more things, but to collect that information in the workflow. And right now, while we have electronic medical records, our electronic medical records were designed as reimbursement tools that are really revenue cycle tools. Did I do something? Okay, all right. Okay, that was, all right, well. Good move. That'll keep you awake. So let's go through each of these. First of all, medical conditions. We're all organized in the wrong way. We're organized around specialty societies who create the rules for the reimbursement for specialties. We're organized around facilities and interventions, but we need to be organized around conditions. We're not going to create value by organizing around surgeons and anesthesiologists, but we are going to create value if we organize around the conditions that patients have. Because when you have integrated care, everybody becomes responsible for the care. It isn't, and again, I'm using the anesthesiology example, we were focused on about 6 hours of a patient's life. And we missed some of the big pictures of things that we needed to do before surgery and after surgery that would really improve care. But because we were being paid for those 6 hours, we focused on nothing other than that. Surgeons have the same narrow view, but the medical condition exists over an entire cycle. Here's how MD Anderson reorganized itself. In the early 1990s, the president of MD Anderson said, you know, it's crazy that we've got radiation oncologists in one place, medical oncologists in another, surgical oncologists. Let's put all of the patients in one place and have those people come and visit them. And this is an example of the head and neck center. Juan, I'm not quite sure why this doesn't point, but the top one, Preston Hall. All right. And Juan did tell me how to use this, but I guess I didn't. So the old model was we had people scattered all around what became a large geographic area and included a speech center and a swallowing center, primary care physicians who weren't even located nearby, radiologists, dentists who weren't even on site, pathologists who worked in their own areas. And when we reorganized to these different disease site centers, we put the medical oncologists, the surgical oncologists, the radiation oncologists, and the dental services all in one place. And so the patients learn to come to those places, to come to those centers. And what happens when you do that? Well, when you do that, you are able to give care over an entire cycle, from early detection to the diagnosis, to preparing those patients, to intervening, rehab, and later follow-up. And these types of integrated practice units become like the home base for patients. Patients get to know everyone, and everyone develops a real bond in their care. I'll give you these slides. I'm not going to read through all of them. But basically, an integrated practice unit is one where everybody's on the same team. and the patient is at the center. And what you develop is an increased knowledge at a subspecialty level of the condition that patients have. So everybody becomes expert. The nurses become expert. The clinicians become expert. The dentists are seeing everything with respect to those patients. And you develop what Michael called in 26 a virtuous circle of value. And that is, you start with a medical condition, you get a lot more experience very quickly, you get better information that leads to more fully dedicated teams. The facilities become really focused on what those patients need. You get more efficient, you get more subspecialization, and as you get bigger, you have greater leveraging in cost and purchasing. You're able to innovate faster because you have more experience, and your reputation improves. And this circle of value, when we first saw this, we took what we did at MD Anderson and we put around all of the things that we were doing, and we felt, yes, this really makes sense. It made a lot of good sense to us. In primary care, it's a little more difficult, but if you think about primary care, you really you can't think of primary care as everything, but there are segments. You can segment healthy adults. There are patients who are at risk as adults. There are patients who have multiple chronic conditions. And we can segment these various primary care segments of the population. And we're starting to get good examples of how to do that so that these primary care teams can organize themselves around segments. We have a case describing a program that started in Chicago called Oak Street Health. And Oak Street Health focuses on dual eligible elderly patients in the inner city, and has created all of their care and are reimbursed through managed Medicare in a capitated manner, but they're focused on just those problems of elderly dual eligible patients living in an inner city. And they're not worried. They will readily admit, we can't take care of a healthy 35-year-old. We don't want to. Our segment is this. And they do a great job, and their outcomes are great. They've developed, as we're seeing, these specialty practices, or these specialty primary care practices, develop relationships with specialists and are able to basically lead their care by appropriately integrating with specialists. But what do they have? They have dedicated teams. They're appropriately integrated with specialists. They share infrastructure, they use telemedicine, they provide lots of good services after hours, and they do a lot of prevention. And they're able to do other things like provide transportation. And with some of these managed Medicare programs with Medicare Advantage, they get a lump sum payment, and they're able to provide for transportation. Now, Oak Street is probably our best example. They've expanded to over 40 sites throughout the Midwest, but they function as a team. And I think the bottom line in all of these integrated practice units is they're a team. Now, the second piece that we talked about is measuring. And outcomes are what we went into healthcare for, was to help patients, for patients to have good outcomes. We sometimes lose sight of that when we start to measure infection rates and, compliance with, did we give antibiotics at the right period of time? But if you think about it, the focus of care should be on the outcomes. And when we started thinking about outcomes in a cancer center, we asked the doctors, what do you think are good outcomes? And they said, oh, well, cancer, it's survival, 3 and 5 year survival recurrence rates. We did an interesting exercise because we were along with the Cleveland Clinic and a number of other of the comprehensive cancer centers, we were under a lot of pressure to publish our outcomes. And so, we went to the oncologist and they said, of course, it's got to be survival rates. That's all the patients care about. We had a chief financial officer. That's why I like being in the business school. It's like sometimes the finance people say really interesting things. He said, well, that's really interesting. That's what the oncologists think. What do the patients think? And so we started doing focus groups with our patients. And we did them by condition. So we had a breast cancer focus group. We had a head and neck cancer focus group. We had a prostate cancer focus group. And we had several others. And we did it in not with a doctor sitting there, but with a marketing person kind of saying, well, what are important outcomes for you? We didn't hear survival rate. We didn't hear, well, I really chose MD Anderson because I thought you had a low recurrence rate for my cancer. We heard issues about quality of life, quality of treatment, patient experience. Our breast cancer patients, a lot of the breast cancer patients said, well, we didn't even think about survival rates. We assumed we were going to survive if we came to MD Anderson. We were concerned about what our friends would think about us, what our significant others thought about us. And those were the outcomes that were important. What was my life going to be like? Was I going to be sick during chemotherapy? And so the light bulb went off with a number of us. It's like, well, gee, I mean, it's wonderful to approve a drug based on survival, but quality of life measurement has to be part of these outcomes. And we started listening to our patients. Now, that's not to say that patient experience isn't an important outcome. It's not to say that process measurement, measuring the processes by which you get there are important, but those shouldn't be the sole things that we focus on. Structural issues, they're important. And indicators, they're all important, but we really need to have a better focus on outcomes. And interestingly, when we look at the reimbursement system in America today, the measures that have been tested and validated and go through an organization called the National Quality Forum, most of those are process measures. Why? Most of them came from specialty societies. The specialty societies said, oh, well, you know, we can do this. So for cancer, the things that we were being measured on were things that we achieved 90, 95%. You know, well, we did it all the time. We were great. Everybody was great. But you don't want to be great at everything. You want to be able to improve. And if you start focusing then on the outcomes that matter to patients, you have some goals that are important and that the patients will agree with you about. Now, principles of outcome measurement. They've got to be condition-based or in a primary care segment. They're always multidimensional. And I'll show you a couple examples. You're never going to have one outcome that's going to be important for every single patient with a condition. And in fact, for some patients, an outcome that was important for one patient might not be important to another. Our values are all different. It's an issue of perspective. I have a certain perspective in my age, which is different from the perspective of somebody in their 30s. But all of these things need to be taken into account. They're always multidimensional. We have to think about this role of patient-reported outcomes. Patient-reported outcomes are going to move more into the mainstream of our thinking about what's important. And there are many, many validated patient-reported outcome tools that are out there, but in general, they haven't been extensively used in clinical care. They've been mostly used in research and in drug evaluation. But there are doctors now who use them and say, it really helps me to know what my patient is thinking about their course. And having these validated tools makes a difference. You've got to cover the full cycle of care. It goes through that entire spectrum from early detection, prevention, early detection, all the way through rehab. It's not sufficient to just say the patient, you know, what was the surgery outcome? 30-day survival. We got them off the operating table. Okay, they lived 30 days. We're good. What was their quality of life like a year later? What was their quality of life like 5 years later? Those are the important things that people should be thinking about and our patients should be thinking about. By the way, is this working? You're all happy with this? Good. I didn't sometimes no news is good news. There has to be risk adjustment. No one is saying that this is easy. This is not simple, straightforward. It requires some degree of effort to do because not everybody is created equal, and an outcome for a patient with multiple comorbidities is going to be quite different from an outcome for somebody who's completely healthy. So I'm not portraying this as something that is so simple to do. It's like, oh my gosh, why haven't you done that? It's not that straightforward to do. Outcomes, though, need to be standardized. we have to agree on what it is that we should be measuring. And right now, there aren't really great, when I mentioned the National Quality Forum, they don't have lots of outcome measures because there isn't a lot of agreement. We're now, and I'll tell you a little bit about our nonprofit, which is developing outcome measures that matter to patients so that we can build these into the system and start to use them center by center and be able to compare and benchmark outcomes that matter to patients. And they should be measured while the patient is getting care. This shouldn't be something that you have to depend upon the fellow to go back and enter. I once we had a great thoracic surgery database at MD Anderson, but the surgeons would always say, well, the database is only as good, the outcomes in the database are only as good as the fellow on that month. It's like, well, great, this is what you're relying on. And those of you who work with large databases, you know what I'm talking about. It's the reality is we have electronic systems now. We should be collecting this in the workflow through the tools that we're currently using electronically. But as I've mentioned earlier, our electronic records were created as revenue cycle tools, not as tools to measure clinical outcomes. And so we need to make those sorts of transitions. And interestingly, the IT vendors are starting to listen. Epic is starting to listen. They're realizing that this needs to really happen. But the final thing is that value-based healthcare is different from what we've been historically doing. And I think that once you acknowledge that, you'll be able to sort of realize that this is not going to be an overnight transition. This is going to be an evolutionary change, and you can't expect things to change overnight. Number of years ago, Professor Porter came up with this outcomes hierarchy. It's pretty straightforward. It's several tiers. The first tier is survival and how well you do initially. The second tier is some of the times to recovery and to return of normal activity. Disutilities of care or treatment complications are really important. And then the third tier is how sustainable is your health? How well have you recovered? And those are the types of things that when we think about our own individual silos, we sometimes forget about. Now, when you report outcomes, behaviors change. This was these are severity adjusted outcomes of graft survival in renal transplantation in the first few years of collecting this data between 1987 and 89. And as you can see, there was a real scatter amongst transplant centers of what their graft survival was. To get an organ in the United States, you have to report your graft survival. Over time, here's what happened when people started reporting those outcomes. And don't mistake me, this wasn't solely because they were reporting outcomes. But what happened was after the reporting of outcomes and people started saying, well, we all need to achieve that high outcome, the outcomes improved. And the same thing happened with in vitro fertilization. In vitro fertilization used to be terribly unregulated. Outcomes were very, very variable. When they started publicly reporting outcomes and people started paying attention to, oh, this is important for us to be, the in vitro fertilization rates, their success rates in terms of pregnancies improved, and they became consistently higher. So public reporting in many, many venues will help. If you're in an individual practice and you report the outcomes of a group of surgeons, I guarantee you the surgeon who is performing more, it's the right adjective, the poorer performing surgeon is going to want to be up with the other performing surgeons. If you don't collect those outcomes, nobody knows and nothing ever happens. Now I said these are multidimensional. We have a case in prostate cancer care, and our best hospital, the one that we're focusing on, when it came to 5-year survival rates, our sort of test hospital had pretty similar overall survival rates to the average German hospital. But when you start looking at other outcomes beyond survival rates, look what happens. The best hospital has erectile dysfunction rates down in the range of 17%. The average hospital dysfunction rate was over 75%. Incontinence over 1 year was dramatically different. And these are traditionally patient-reported outcomes. You can get this as a clinical outcome, but those who do patient-reported outcomes say these types of personal things are best reported by patients. And so these multidimensional outcome measures have to be collected in different ways from what we've traditionally done. Now, I mentioned a nonprofit. In 2011, Harvard Business School partnered with the Karolinska and Boston Consulting Group to form a group called the International Consortium for Health Outcome Measurement, or ICHOM for short. And whoever came up with that needs to be punished severely because it doesn't make any sense and it doesn't flow. But they have, over the course of several years, come up with quite a number of outcome measure sets in a collaborative process that's done bringing clinicians from around the world together with patients with those conditions and asked what are in those multidimensional categories, what's really important. And now ICHOM has moved on to helping people implement those outcome measurement tools and beginning programs of benchmarking centers to center so that people can compare outcomes for these various clinical conditions center by center. Now, cost measurement. We all think we measure costs, but there was we were talking earlier, and we were talking about an article. Adam and I remembered the article, which is really would pierce the heart of everybody at MD Anderson, written by a person by the name of Steve Brill in Newsweek, who pointed out how our charge master at MD Anderson was really totally crazy. That we charged incredible amounts of money for things that people would say, no, we know that doesn't cost that. And then had other things that didn't balance, didn't make any sense. Cost shifting in American healthcare has been the sort of the norm for many years. We charged what people would reimburse us. And so you had a $14 aspirin because no, everyone's going to reimburse the aspirin. Those charge masters were just incredibly wrong. Now, oh, okay. So every time Juan gets nervous, I get nervous. So if our charges are really not based on our costs, what do you think happens when we do cost measurement based on cost to charge ratios, which is what everybody in health services research uses? It's not accurate. It is absolutely not accurate. So in 2010, Professor Porter called up Bob Kaplan, who is there is an Accounting Hall of Fame. And Bob is a member of the Accounting Hall of Fame. And he said, look, you need to do activity-based costing. You need to take your medical condition and you need to follow the patient through everything that they encounter and accurately measure who's working with that patient for how long, because you know what you're paying them and you know what your supply costs really are. And you need to look at every single thing that happens to a patient, and then you'll get an accurate measure of cost. It's got to be done over the full cycle of care, and it's not the sum of the charges or things that were billed. We started doing that at MD Anderson, and we were amazed. There were things that we didn't charge for that were incredibly expensive, that we were never reimbursed for. We had multidisciplinary care planning meetings that we brought all these doctors together and we couldn't get reimbursed for that. but that was a cost of doing, that was a cost. So the way that you get at this is by mapping what happens to every patient. This is an example of our new patient visit. And what we do is we take every single patient and follow them through the system. And when sometimes things happen, not every patient for every period of time, there are probabilities of where that happens. But for every category of provider, there's a certain average number of minutes that are spent. And when you add it all up, the end result is a real actual cost for that particular thing that happens to patients. Now, interestingly, this has been done for years in lots of other industries. And Bob said, well, I've got a great IT firm that can help you do this. And so we had this IT firm come in and they said, oh, well, you probably just, you've got a couple processes for your patients. And we said, no, actually for a head and neck patient, we've got about, maybe 200 processes. They couldn't manage that. So healthcare is really complicated. So there are electronic ways of doing this. Lowe's, Coca-Cola, lots of banking industries use activity-based costing all the time. Healthcare doesn't because of the complexity. And so doing it is hard. But when you do it, you learn a lot of different things. You learn that in healthcare, we have a tenfold difference in the cost rate for people doing the same thing. When you have a medical assistant doing a history and physical and a surgeon doing a history and physical, and the outcome of that is pretty much the same, you've got people with a tenfold difference. As Bob Kaplan pointed out, there's no industry in the world that does things like that. But we can understand that, and we can do things better if we understand these costs. There are lots of opportunities. One of the greatest opportunities was just from that first example. We need to have people working to the top of their license. And we shouldn't have doctors doing things that can be done by somebody with a lower cost rate just because we traditionally have done that. The fight between doctors and advanced practice nurses. Gosh, where's our, I'm looking for the student who was here earlier. Oh, there you are. So when you practice, look, don't get hung up over the fact that a nurse can do the same thing that you can do. Be thankful that he or she can do that and turn that over to them and focus on the things that you as a doctor are going to be able to do. But we've got to get rid of this battling. Anesthesiologists battled for years with nurse anesthetists. It's like, give it up. There's no difference in the outcomes of nurse anesthesia versus physician anesthesia. So figure out where you can add value to the system. Eliminate low added, non-value added services and tests. Right now we do so many crazy things. We were talking about prostate cancer things now. Everybody gets an MRI now if you've got an elevated PSA. Are you kidding me? They did just fine without MRIs before all of this. Eliminate process variation. We found at MD Anderson that when we started doing process maps, we realized that almost every doctor had a different process. That can't make sense. That can't be good. And sometimes, talking to an in vitro fertilization doc yesterday, sometimes they do 5 ultrasounds. Sometimes they do 1. Outcomes are pretty much the same. But let me tell you, the person, there's a different cost to each of those. Reducing cycle times. All sorts of things, service duplication, people doing the same things and repeating tests. We don't have good interoperability of our medical records. So I don't know how you function here, but if somebody was treated at NYU, I'm not, again, depending upon their medical record, are you reproducing things that they had done in Manhattan that you're reproducing here because you don't have the results? And yeah. Yeah. Yeah, well, no, but that's common. But that is crazy, and that's why our healthcare system is so high. Now, value-based reimbursement. I'm not going to spend a lot of time talking about this because, as Adam and I were talking about earlier, this is a huge topic and something that people need to understand better. There are 2 emerging value-based reimbursement systems. One is capitation that exists in most of the ACOs. and in the Medicare Advantage programs, where you're paying where a single amount of money is paid to a program for the care of a life. And then there's bundled reimbursement, where there's a single lump sum paid for treatment of a given condition. And if it's a chronic condition, over a period of time. And both of those require some degree of measurement. The measurement systems in the capitated programs haven't been as good. The bundled reimbursement systems still need better outcome measures. But both of these allow providers to be paid based on their outcomes. And they push the responsibility for the good outcomes to the provider, so that you're rewarded for a good outcome and you're not rewarded for a poor outcome. We did a pilot with United Healthcare for head and neck cancer. Our patients loved it. They had simplified, they got one bill and one explanation of benefits. If you know cancer patients, they're constantly in agony over multiple bills, multiple explanation of benefits, and nothing matches anything else. They knew their out-of-pocket costs right away. We were able to consult with them right away in terms of what things were, and that the coverage issue didn't necessarily influence their care, that they got good care. There are lots of bundled issues that we can talk about where patients fear some of this, but what did we get out of it? Well, we got some early experience with doing it. It was a simplified process, and we used it as a lever to measure our outcomes. Interestingly, United Healthcare was interested in doing this with us because we knew our costs. If we were stupid enough to venture into this without knowing our costs, we could have lost a tremendous amount of money. As it was, we negotiated a good price, and we actually made more with those patients than we would have made in fee-for-service. But these things required some real adjustments. This wasn't easy to do. I thought, send them one bill and you send us one check. Oh no. Claims management in healthcare these days is all automated. And we had to extract these bills manually so that they wouldn't get the automated claims that were sent. And similarly on United Healthcare side, they had to pull those things and extract them so that they could pay them. And so we need some major revisions in our technical reimbursement system for these things to take off. But lots of interest amongst the people who are helping us pay for our healthcare, and those are our employers. Walmart has developed centers of excellence programs where they pay lump sums for treatment of certain processes. And as of course you all know, Amazon and their partners are trying to figure out how to address this. So the employers are getting into this in a big way. System integration is the next piece of all of this. Defining what should be done and doing the right thing in the right place is incredibly important, because you end up having more volume in the places that can do things well, and you don't try to have every organization do everything to a level of excellence that they actually can't achieve. We have a number of examples. Children's Hospital of Philadelphia probably has one of the nicest examples of integrating primary care and specialty care, doing the right thing in the tertiary center, that is all the complicated surgeries and all of the complicated stuff is done in the main center, and that everything that can be done in the community is done in the community. There are lots of other examples. This is the same thing, Rothman in Philadelphia for hip and knee replacements. If you're healthy enough to have your hip and knee replaced in the periphery, the hip replacement cost is about $12,000 in one of their ambulatory surgery units. If you get admitted to Jefferson, it's about $45,000. So you really, if you're healthy, you really need to be done out in the right location, and not automatically done in the main center. At MD Anderson, we started branching out into a number of satellite centers with a integrated program with the main center. So in head and neck cancer, if you needed an operation, you got it done at the main center. But if you needed chemotherapy, that was done out in the periphery in a lower cost environment. But we didn't try to reproduce things. We didn't try to reproduce every single surgical procedure in every one of our partner locations. We developed a center of excellence program, and we tried to make sure that all the care that was delivered out in these partner programs was similar to MD Anderson care, and we tried to get the more complicated cases sent to our main center. Cleveland Clinic has done the same thing with their cardiac program and their renal transplant program. Children's Hospital in Texas is doing the same thing with pediatric cardiac surgery. And Vanderbilt has developed an affiliated network of affiliated partners. They're not buying these practices, they're merely affiliating with them, but they're offering value because those patients now in a pretty wide geographic area have access to Vanderbilt care when they need it. Final piece of all of this is an enabling IT infrastructure that integrates all of the data. We need to get over the business of we must dictate every note, because you cannot take unstructured data and get any data out of it whatsoever. So we need to move to more structured data. Data needs to be captured in the clinical workflow. There needs to be full interoperability of all of our delivery networks. Need to be able to see everything that everybody had done, as long as your HIPAA requirements are met with that caveat. But we can't keep reproducing every single service. Now, if you think about all of this, you can't do one of these without doing the others. You can organize around integrated practice units, but to measure outcomes and costs, you have to be organized around integrated practice units. You have to be thinking about care and the conditions. To move to bundled reimbursement, you've got to be measuring your outcomes and you have to know your costs. You really need to know your costs of delivering care to rationally provide care in the lowest cost environment. But unless you're measuring your costs, you really have no idea about that. And finally, you do need this integrated platform. Now, what are the things that need to happen? Well, first of all, there needs to be a common language. When we talk about value, everybody has to be talking about the same thing. We found that people speaking the same language could collaborate, engage each other, talk with each other about value, and pilot small portions of this agenda. We never took all of the value-based healthcare. We couldn't do time-driven activity-based costing for all of MD Anderson. We couldn't measure all of these outcomes, but we were able to develop pilots in individual areas. And one of our partners, who was the CEO of an orthopedic institute, she said early successes where she could demonstrate where this helped made it easier to do subsequent pilots. So you've got to take off little pieces of this at a time. We had a value institute. I mean, we didn't call it a value institute, but we had a value institute. We're doing some work with the government of Wales. Their initial idea is to have an institute in one of their universities devoted to value, but then train each district to have a value institute to work on these processes. This is different from what we would call performance improvement departments or quality improvement departments. Our Value Institute was really more research oriented. It was more, let's see what we can do with this, while the quality improvement folks did their other work. And then I will have to say the education of this is really important. And I was delighted that Rob invited us here and took one of our courses. But education, and starting with medical students, with public health students, with people who are going to be in healthcare for the next 30, 40, or 50 years is really essential for this to really take hold, and working with skilled coaches. Now, the last thing, why is it that healthcare is the same? Change is really difficult in healthcare. Every place has their local traditions. I moved around the country a couple times. man, it was really crazy to see how ICU medicine was practiced in 3 different parts of the country. And of course, I learned very early on, I shouldn't say in San Francisco, well, you know, in Boston, we did it this way. That really did not go down very well. They shut me down very, very quickly. You're really busy in healthcare. Doctors and nurses don't have time. They come in, they can recognize that the system is broken, but they don't have an ability to fix the system because it's like, well, we've got a whole list of patients and we've got a list of cases in the operating room. And so change is difficult because the operations are busy. There's plenty of time to understand that there's change needed, but there's not a lot of time to reflect on that and come up with a plan. My big peeve is that for years, we have not in healthcare trained leaders appropriately in change management or in the business of healthcare. And leadership selection in the academic medical centers has really been sad. And, you know, so how was I selected at MD Anderson? I had a big list of peer-reviewed publications. I had peer-reviewed funding. They thought, wow, he comes from Stanford. He's written all this stuff. He can manage our department. I walked in there and they gave me a budget of about $180 million a year. And the state of Texas said, now you sign right here, doctor, because you're responsible for that money. And I thought, God damn well, I hope I got good help because I could balance my checkbook. That was the only finance training I had. I never had any human resources training. I didn't know how to manage classified staff, but I had 350 employees. I was no more prepared to do this than anybody that you took off the street. But they selected me for all of these things. I'd had leadership experience. I'd run our fellowship. That's great. I had the endorsement of the search committee, but even the bigger endorsement was there was a search firm. And search firms ask the same questions. And, you know, sadly, whether you were a good doctor, that was a plus if you were, but if you weren't, you know, we overlook that because, you know, we want the peer-reviewed funding. I'm not kidding you. This is, you know, and go to Boston, you'll see it happens there. What do we need in the future? We need people who have a vision and a framework. And I would sort of postulate that a value-based orientation is be really important for leaders of the future. One must have some management training or experience. You really can't manage people in this day and age without that experience. Healthcare is highly matrixed. You've got to be able to be the sort of person who can work in a highly matrixed environment, and you have to have some financial and resource capabilities, and you've got to be a good communicator. I found that 98% of the issues that related to problems that were brought to my office were related to poor communication amongst everyone. It didn't matter. And then it really does help to be a good doctor and be a good investigator because you have to do it. So this is underway. This is the path forward. We believe the value for patients is really kind of the true north of where things need to go. I've looked at all of them and I wouldn't be standing here and saying this if I didn't think it. Value-based thinking can help you restructure care and strategy and payment. We need standardized outcome measurement and cost measurement. The interesting thing is employers are getting this. The supplier industry of these courses that Rob took, I don't know how, at least a third of the people who took the course when Rob took it were from the supplier industry because they know we're going to be paying for value. They know you just can't put a product out there and sell it for whatever you want to sell it for. And the pharmaceutical industry is concerned. And the government has been, in the United States, the leading sort of proponent for value-based healthcare. Sylvia Burwell, in her role at CMS, was a tremendous advocate for value-based reimbursement. We're anxious to work with all of you. We think that this is, that educational organizations are the way to transform the future. I'll give you all of these references, but I thank you for your patience and for your interest in having us here. So thank you very much.
Thank you so much. I have a feeling there could be a few questions. There just might be a few. Was everybody excited as I was to hear this? I think this was really an outstanding presentation. I think that Dr. Viola might just possibly have a question or even a comment. Please also, for Dr. Feeley's benefit and everybody else, please say your name and where you're from. Who are you?
Deborah Viola. I'm at Westchester Medical Center Health Network, and I'm responsible for your item 6, essentially developing the IT solution and platforms to achieve this work. So two questions. First, one is driven out of curiosity. You used terms like giving the patient what they want, very patient-centric. You had focus groups. You talk about outcomes that are important to the patient. So I would say they're consumers, and I was just curious why you haven't introduced the term consumerism in your presentation, because it's just curiosity. And then the second question is really about, and it comes from a colleague on Catalyst who commented on your report. So I don't know if this is intentional or by default, but if I'm on the hospital side, I understand if you push me from fee-for-service to population risk-based. But you're talking about value-based contracts, which will still be defined differently for every single contract that you go into. And so your colleague had commented that the value-based contract was just one step, that we're going to go from fee-for-service to VBC to population risk-based reimbursement. So I'm wondering, is that intentional by design, or is it more by default?
Well, let me do the first one. And that is, I could call it consumer-based because I think it is. I mean, I just tend to not like to call our patients consumers, but they are. So, you know, that's fine. No, this is not a grand design. And I would say that there are very competing academic differences. In fact, I was once put on a panel with a gentleman from Dartmouth who, Eric, help me out. Fisher, the person, Elliot Fisher. So we were on a panel together. It was a panel of 2 of us. I had done bundled reimbursement, and Elliot had proposed ACOs and was one of the fathers of the ACO concept. I think these are emerging in parallel. I don't think that there was any grand design that we would transition for bundled reimbursement or ACOs and capitated payments. If you remember back the 1990s, we tried capitated payments, and capitated payments really failed. Certainly in California, I was in California at the time. They failed. And I think the problem with capitated payments is that it's really hard to get a measurement of the quality of what you're doing. So it as a value-based payment, and I really ask Adam to weigh in as well, but as a value-based payment, it's really tough because you're not rewarding for a given. God bless everyone who likes population health. I don't know what a healthy population looks like. I don't know what that measurement really is. There are so many different measures, whereas I know what a good outcome in lung cancer is. I know what those outcomes are, and I can much more easily envision bundled reimbursement being a value-based reimbursement when you think of medical conditions. I have a lot more difficulty thinking how capitated payments are actually really value-based payments. And again, because we're looking at a lot of process measures and things that aren't in the right. So I'm a bundled person, but I don't see it as a bridge to population health. I think, but in that panel, so we were each asked to ask each other a challenging question. So I asked him, "Are ACOs working?" This was about 3 years ago, and he said, "We have this number of ACOs," and gave us I said, "Really? A number of ACOs is success? What about, are patients healthier?" And he got a little cross with me. rightly so. And he said, well, how long did it take for you to negotiate that bundled reimbursement with United Healthcare for head and neck cancer, which ain't exactly your commonest disease? And I said, well, about a year. And he goes, okay. So let's multiply that by every payer and every condition and every provider organization. And do you really think that that's going to happen? And I said, well, we can make it faster for another condition. But the point is, it is hard. All of these things are hard. ACOs are easier to implement because you can do it on a much larger scale. Bundled reimbursement is really tough to do because every provider, every payer, and every provider has to work and negotiate through those things. So, but it's not and I missed that comment, so I didn't see it. But, okay, any other questions? We may be out of time.
Yeah, I think, and by the way, some of the folks who are getting up and leaving, what you just said.
School is in, yeah.
Another class going to start.
Yeah. Yes, sir. Oh, wow.
Also the chief of OB/GYN at Westchester Medical Center, you know. But it was interesting, and you and I were in the Bay Area together. You were at Stanford. I was the chief of OB/GYN at Alta Bates Hospital in Berkeley. But in 1975, I was blessed to have been a Kaiser physician at Kaiser Oakland. And the hospitals were cost centers, and that we all were on salary, and that, and it was health maintenance. And when a patient joined Kaiser, they had to see the primary care doctor who totally evaluated the individual in that. And there were some young women, 28 years of age, and that with BMIs of 50. And what would happen? The primary care doctor would say, okay, you need to see the dietitian. So it was preventative health in that. And we were on salary. And at the end of the year, if Kaiser made money and that, then what they did is they gave us a little Christmas bonus, okay? And that, but I left there after a year, but the CEO said, you have been introduced to medicine of the future and that. So I think that health maintenance organizations, properly organized with hospitals as cost centers and the focus on health maintenance and the appropriate provider for that is what we need to do here in the United States. You know, I also was blessed to have developed a capitated large medical group, the Alta Bates Medical Group I formed back in 1983. There were 500 of us there. But what we did, we the specialists, and that I negotiated with the CEO of the hospital that half of what the hospital gets had to go back to support primary care doctors and that. Yeah. And the hospital hired, okay, anesthesiologists, the radiologists, the pathologists were all hospital on salary in that. So you didn't have the incentive. Our incentive, where we made money with capitation, was to keep the patient out of the hospital and keep the patient healthy. The reason that we failed, we were in there for 5 years, and that the reason that we failed, we were making money and the hospital was making money and that, but the reason that we failed was that patients, there was a backlash on the part of the patients who said, no, I don't want the primary care physician. I want to go to my cardiologist, or I want to go to the respiratory doctor, or I want to go to the OB/GYN, you know, for my pap smear, not this primary care doctor and that. So what we have to do going forward is get back to that concept, you know, and that it's about health maintenance. And that would be the most cost-effective way for us in the United States to take care of patients.
Yeah, I agree with you on so many things, including the salaried physician piece. We were all on salary at MD Anderson. And look, the surgeon was paid the same thing, whether he did 50 prostatectomies or 500. And so there was not that pressure. Well, I've got to do these procedures. So that was number one. Look, we're really excited about doing a value-based healthcare program in Wales, because they have a system in the National Health Service where you can't go to a specialist unless your general practitioner sends you there. And we need to better integrate, and we need to have primary care in the United States valued. I mean, primary care in the United States has really been decimated by specialties over our time in medicine. It went from something, when I was growing up, our primary care doctor was the person we saw. That was who you saw, was your doc. To people wanting to, oh no, I think I have a GYN problem. I want to go directly to a gynecologist. Well, you know, your primary care doc could probably have handled that. Plenty of examples where that needs to transition. We're seeing some real good evidence of that. The Oak Street Health, that program in Chicago that I was telling you, they have decreased by coordinating care. They have decreased and getting payment for health maintenance, if you will, through their Medicare Advantage payments. They keep people out of the hospital. They figure out, oh, those patients, do they want care at end of life that involves a hospital? And they're able to sort of determine, you know, what's valuable to this patient. But right now in the fee-for-service system where, you know, I'm sure that urologist who said, well, you need an MRI, there's some perverse incentive for that. And it isn't for my well-being. But thank you for your comments. And yeah, I do remember, I was the president of the California Society of Anesthesiologists. We weren't too pleased with you all, as they say, when you were hiring the anesthesiologists. My constituents were fee-for-service. So I do remember what you did. Anything else? I know we're running out of time.
One more question. None.
We're good. Yeah.
It's a great holiday season coming up. I want to thank you again.
You're a lot closer.
And we hope that use this. Oh, yeah, you did.
I did.
I just thought, accent, right? Maybe New York. We want to give you a much friendlier.
Yes. Yes.
Remember again. And I appreciate Aline getting us back.
And Dr. Feeley did.
And yes, thank you all. Please drive safe, Godspeed, and don't.